Hi, so I'm Lionel. I use they, them pronouns, and some etiquette things before we start that I'd really like to empathize is if the panelists can use the raise hand function before answering, that would be really great, given that we have ASL interpreters today for my use as well. And then two, if you could state your name prior to speaking for the convenience of the interpreters as well. That would make it clearer who is speaking. And three, if you could pause at the end of your portion of the presentation so that the interpreters have time to catch up with what's being said, that would be really appreciated. So all three of those things, if we can keep those in mind going forward for this panel, thank you. Um, so I can read out the bios, but first I can go down the list of people who are on the panel. But Vera, do you want to introduce yourself? I see your hand is up.
Oh, sorry. I was just making it easier for the moderators to pin everybody on the panel.
Oh, okay, perfect.
But I can go ahead and introduce myself really quickly. Absolutely. Hi, y'all. My name is Vera Muñiz. I am a clinical research program coordinator through the Massachusetts Psychosis Prevention Partnership. I have worked in public health spaces since I've moved to Boston, so my entire adult life. I lived in Massachusetts briefly when I was younger while my family was immigrating for a couple of years in Agawam. My brother worked at the Six Flags there, and like my dad worked in Springfield. But I spent most of my time in Tampa, Florida, and now almost half of my life here in Boston. I got a lot of my harm reduction work started doing HIV and substance use prevention via Casa Esperanza down in Roxbury, doing a lot of prevention focused primarily on cannabis, nicotine, sex education, and psychedelics. And now I've shifted primarily to doing work in the early psychosis realm. So I think I'll pass it off to my colleague Locke, if that's okay.
Hello, thank you so much, Vera. My name is Locke Ironwood. I use they, them pronouns. I'm here to speak about harm reduction and my experience therein. I'm a peer specialist. I was certified in 2020. Aside for that, I've been doing lots of different grassroots organizing around Black and Brown transgender individuals in the city of Boston. I am a Boston native. My family is historically from Boston, and I've sort of lived everywhere from Roxbury, Dorchester to now on the North Shore. So I'm just kind of all over the area. I'm very familiar with the queer community in Boston. I'm very familiar with how West Indian populations, like my own family, um, have come to this city looking for just sort of for community. So I have a lot of experience in that way. Right now, I serve as the co-chair with Vera on the MP3 Lived Experience Committee, and I'm also working as the mental health coordinator at the Lindemann Inn. Thank you so much. Um, I guess I'll pass to Riot.
Thank you, Locke. This is Riot. My name is Riot Diaz Paniagua, and I use all pronouns besides she and it. And I have been a community organizer and educator for almost 12 years and a harm reductionist for, I would say, like 1.5 years. Um, I specialize in direct aid and making sure folks' needs are met. However, they advocate for themselves to me, I try to support them in getting whatever they need. Um, I was born in Boston, and then I moved away into the suburbs, and then I moved back to Boston when I was 8 years old. And then I've been in Boston for that entire time since then. And I'm 28, so that's 20 years back here in Boston. So I teach high school. I'm a high school educator, and then pretty much the rest of my time is taken up by community organizing. I run my own kind of grassroots collective. It's called Mutual Aid is Magic, and I go out and I table and at different events, usually as part of the queer community. So maybe drag shows and parties and raves and things like that. But also, I'm open to festivals and things of that nature. And I just offer free resources like harm reduction for safer drug use, non-carceral mental health resources, and safer sex supplies, to name a few. Um, yeah. I think that is it, and I will pass it off to whoever would like to speak next. Thank you.
That would be Jill. And then I'll go last and introduce myself as the moderator for this harm reduction panel.
Hello, everybody. Thanks for having me today. My name is Jill. I use she, her pronouns for now. Where to even begin? I spent a long time working in direct service, specifically in harm reduction, about 17 years. I've had probably almost every position you could have in harm reduction, which has given me a really broad view of the work at different levels and supporting staff. So I think, yeah, I just, right now I work in peer grief support specifically for the workforce, including harm reductionists, recovery coaches, MDs, nurses, whoever we really come in contact with. And that's a BSAS funded program. And something I was just thinking of that I forgot about for a minute that Riot had mentioned was my personal history with harm reduction goes way back to my rave scenes and all of that and doing harm reduction work in New England quite some time ago at this point. And so there's a lot to talk about when it comes to different harm reduction that I'm excited to get into today. I think that's pretty much all about me. I didn't know we were introducing ourselves, so I'm just kind of thrown off right now. Thank you.
No, absolutely okay. This is Lionel speaking. So I'll be brief with my introduction just so we can get to the meat of it. I'm Lionel, you know my pronouns, they, them. I'm a deaf disabled mad person who I wear a lot of hats. I think the main ones that I wear are as a cross disability communities connector for the Wildflower Alliance, under the Wild Ivy Social Justice Network. And I'm also the chair of the Council Against Institutional Psychiatric Abuse with the Disability Law Center as an advisory board, which Vera and Locke are also part of. And I think my background in harm reduction really began informally, South Shore, Massachusetts, when I grew up in New Bedford. And I grew up going to the public high school, and there was a lot of drug use in the high schools at the point that I went, and I really got to see the kind of harms that abstinence-based programming had on the students there and on the people in New Bedford. And I ended up going into direct care and support for about 10 years now, I think, in a formal and professional context. Uh, Thank you so much for coming. I really appreciate it. And is everybody good to start with the questions? Perfect. I'm seeing a thumbs up. So the first question, and I think you're going last, Jill, because you have a presentation, so I want to be conscious of that as well. But whoever wants to go first can raise their hand. What does harm reduction mean to you? Vera? And don't forget to say your name before speaking. I will call out names before I call on someone, but I just want to make sure.
Absolutely. Thank you for the reminder. Hi, y'all. My name is Vera. Harm reduction to me means that a sort of system of mutual care, I would say. I think harm reduction has been something that for me is synonymous with survival, largely because I've been in a lot of contexts, had a lot of friends, been in community with people for whom like abstinence-based approaches were not something that was feasible for them to rely on. Because the circumstances of their lives were so troubling, so much that they had to deal with, or their use was something that was like significantly supportive to them, that fully abstaining from using any sort of substance or any sort of harmful behavior was more of a risk to their safety than it was for them to continue engaging in it. So I think that's what harm reduction means to me primarily is like survival and community support.
Block.
Hello, this is Locke Ironwood, they, them pronouns. When I think of harm reduction, I go back to the word. What is it to mean to reduce harm? And I think about the root of what that means. And for me, that means removing morality from any kind of harmful behavior. We're not good or bad people for engaging in these behaviors. We're not perfect people. And admitting a lack of perfection gives you a chance to become authentic, right? Your authentic self is not perfect, and I think of that all the time when I consider what harm reduction is to me, is like the forgiveness of like, there feels like there needs to be a forgiveness, especially when you're considering there is a certain moral judgment when it comes to having addictive behaviors from like the general public. So removing that stress from you is like always the beginning of harm reduction to me, as well as using things like fentanyl test strips. I have them in my office at my job myself. Like there are ways in which we can literally reduce the harm, like it says in the definition. So I really stand by that.
Thank you so much, Riot.
Hi, this is Riot. When I think of harm reduction for myself, the term for me has obviously a rooted history in liberation and justice for folks who use drugs. And then also in the same way that I try to like imagine and build new worlds, I think even more so like in different realms of organizing and support for different marginalized groups, um trying to offer things at my table like harm reduction kits, and just like my colleagues were saying, respecting folks' autonomy, right? People know what they need and you just have to listen and not assume that your way is the better way. Certain things don't work for everyone, so just like yeah, respecting folks' autonomy and making sure that they have what they need for whatever method of survival or thriving that they would like to practice in their life. Thank you.
Thanks so much, Jill.
Thank you, everybody, for your wise wisdom words. Before I go on here, it's just really great hearing from people, and being in harm reduction for 17 years, mostly boots on the ground during that time. I've had a lot of experiences in spaces that say that they want harm reduction, but they don't actually know what that means, or they don't know how to implement that into their programming or whatever. So it's really great to have these conversations to get people continuing to think about these things, especially as things get harder out there for everyone. So yeah, thank you. So somebody put up here, Vera put up here, harm reduction principles. There's a few out there. There's the ones that are from the Harm Reduction Coalition. The ones that I teach from now are from Adrienne Marie Brown, and they actually come out of this book called Saving Our Own Lives, a Liberatory Practice of Harm Reduction, which I recommend to everybody. So to answer the question, what does harm reduction mean to me? It's about perspective. It's about perspective. It's about a movement. It's about not forgetting that. Um, and forgetting that it is part, coming out of civil rights movements, and coming out of the women's rights movements and all of these types of things. And when I talk about harm reduction, I talk about drugs like last, because that's not even necessarily what it's about. As Riot was just speaking, it really is about liberation, and harm reduction is rooted from that liberation. And I can just give a few very specific examples of a group called the Young Lords that people may or may not know about. This was a street gang that was Puerto Rican street gang that turned into this mutual aid program. And in the 70s, they actually took over a floor on the hospital in New York, and they created their own detox methadone program. They taught people how to do ear acupuncture, which can help detox symptoms. And that was all, in the community for the community. And it had to come out of this, really intense way of doing it. And I think also too about, Narcan, naloxone in this country. And that was also liberated from the medical system, and that was liberated from a doctor and from somebody named Dan Big, who's no longer with us. They were from the Chicago Recovery Alliance, and they realized, like, okay, EMS has Narcan, but why don't our people have Narcan? Our people are the ones that are responding to overdoses. Our people are the ones that are dying. So they didn't care about liability. And I'll tell you, from someone who has done this work and given trainings in every single setting, detox, residential treatment, shelters, whatever, there's always a question still to this day in 2026 about liability in naloxone. So I'm just pointing out that, the roots of harm reduction really first are not taught to a lot of people that come into harm reduction. So that's a problem that we need to fix. And it's really important that we do ingrain that into people, because they need to understand where this came from. Like this funding and all these things that we can have now, like that came from the backs of people who were Black, Indigenous, trans, queer, marginalized folks. And I feel like that part kind of gets lost, especially when we get into like the public health interventions piece. I could literally talk forever. So is that a good answer? Should I stop now? So yeah, I would recommend checking out the harm reduction principles. Oh, that came out of order. Um, and yeah, again, thinking about perspective and how do we apply. And I'm glad that Riot had brought up self-harm, because that's a beautiful example of where else this can be applied. So I think that's it from me for now.
Awesome, thank you so much. Would you have the time to put the name and author in the chat, just to make sure that people are able to easily access and read this if they want to? Perfect, thank you. So I'll move on to the next question, which is, how do you incorporate harm reduction into your work? And how does that look different on an institutional level versus a community or individual level? We've already spoken a little bit to this, but I'm really excited to explore it a little bit more. Who wants to go first? I'm struggling a little bit with this layout on that.
I
Okay.
can. Oh.
Lock.
So when I think about harm reduction on an individual level, I think about the things that communities are able to do, even reflecting on what Jill was saying. Thank you so much for speaking, Jill, about the transformative power of community. For a lot of folks, there is a hope. There is a genuine hope that families come together and they surround a person experiencing any kind of systemic or harm to themselves, whether that be like harm from society or harm from like any kind of affliction you put on yourself, right? So like, sorry, don't need to phrase it that way. What I mean to say is that when the community surrounds you, it's really beautiful. And when I see that, that gives me hope to bring it onto a more systems based level. Um, because if folks in a gang were able to come up with a system to serve their community, and that's like not necessarily with as many accolades, with as many resources, you know, gives me a lot of hope of like if we're able to adopt more things that were, you know, co-signed by Black and Brown people since the dawn of time, that we can adopt that into systems level care for people seeking help with addiction, seeking help with just like the world we live in, which is just really hard right now. I think that the putting it to that level would be just so transformative. I don't see it there yet, but having conversations like this bring me a lot of hope to, you know, we see this working on the community level and we can put it onto a systems level. I think because systems are mostly focused on abstinence, which like does benefit some people, it's not a whole look of care, if that makes, it's not a whole care model. And I think the care could be much more effective if there were to be some changes around views for what harm reduction really means and how it's not giving up, it's giving care. And I think that's something I would really like to see.
Thank you so much, Vera.
Hey y'all, sorry, having some technical difficulties because I can't react with the hand raising feature while screen sharing. Um, but yeah, I think that the ways that I see it like showing up differently on like a community or like individual level, I think Locke spoke a lot to it, but the idea that like at an individual level, there are individuals who may benefit from an abstinence-based approach. But like what we see from the like even like from like community anecdotal perspectives and also like public health literature, it's very clear that like it is not abstinence as an approach is not something that is widely effective for the general population. Something that is more effective and generally tends to be a lot more culturally competent, I think, is harm reduction based approach because it does place a lot of that autonomy in the individuals that we're working with or the communities that we're working with and allows them to sort of set the stage for how they interact with their supports. And I think that that's what I think when it comes to incorporating harm reduction into my own work is something that I try to focus on. Because when I'm working individually with someone, I may be offering them all the harm reduction options that I may want to, and that individual may not benefit necessarily from a harm reduction approach, and they may find that they actually resonate more with an abstinence-based approach, and I have to be willing to like challenge my assumptions based on that. And also, I think that when we start with an abstinence-based approach as the first thing that we offer people, we lose a lot of like what Riot was mentioning of like what does this person actually need to like feel better, to feel supported? What is this person actually asking for? What is this person saying what their actual struggles that they want to be addressed are? And I think on a institutional or community level, we can look at that as being more as like changing the ways that our structures treat the people who are receiving or asking for these supports and make sure that we're being compassionate and listening to them actively about like what it is that their actual problems are. Because if somebody's coming into our clinic and is not complaining about like their relationship with substances, then that really shouldn't be the focus of our work, especially if like they have other things in their life that they would prefer to be addressed.
Absolutely. No, I really appreciate your perspectives on that. I think like bearing in mind that there is a need that is being met by what they're doing. Jill?
Yeah, I just wanted to speak to this maybe in a different context, just for a food for thought situation. So, sorry, I'm just like rereading the question. So I work in peer grief support right now, a state funded program that is for the workforce, as I mentioned. And I have to, so I consider grief work harm reduction, and I consider harm reduction grief work in some ways. And I think that what I'm finding in with the workforce and people like me, especially who have been around for quite some time, grief circles are not our thing. And what we realized with the state-funded program is like, okay, we need multiple options for people to be able to figure out how they want to move through this work. Because it's not easy and we're losing a lot of people. I have so many friends that are not here anymore and mentors. So it's like a mission of mine to get us to think about also where I was going with this. How do I say? Even within harm reduction programs, there is stigma with staff who use drugs. There is these walls around disclosure, and that is also harming people. So I don't have answers for this. This is an observation as somebody who has been a outreach worker to an assistant director in a vastly expanding program for a few years. So it speaks to this question, and I just want people to think about it a little bit, especially if you're in a leadership position and you have staff that have reoccurrences or you hire people with lived experience. We always want to hire people with lived experience, but then we often don't actually know how to work with people with lived experience and how to figure that out. And that is so important because we need people that have actually lived lives similarly to how the folks that we're working with are or have. So I just wanted to mention that because I think it's such an important point. And even working in harm reduction at syringe programs, this is a big issue sometimes for staff. And it's like, well, so I used to have a drinking problem, right? I don't drink anymore. But I also knew that I couldn't drink vodka or tequila in the bathroom at work, right? So if we're working with a staff person who uses, and let's say they're on some kind of maintenance, it's like when and if like so if I'm not going to drink alcohol at work, this person's also not going to shoot dope at work. So it's like, how do we have these conversations with people? I hope that made sense. I'm having a little bit of a migraine attack in the moment, so I'm going to mute. Thank you.
No, I appreciate that question. And I think like a lot of people come from a perspective of like, we need to save this person's life. We need to prevent a death. And I do really appreciate that perspective. And I think it's a very human perspective. But for me, it's about like, what about this life does that person like think is worth living for? How can we help them access that life rather than trying to, I guess, be prescriptive about how they access that life in some ways? And you're right, grief work. All right, thank you so much, Riot.
Hello, it's Riot once again. May I still answer how do I incorporate harm reduction into my work, or yes? Okay, cool.
Yes, absolutely. Do you want me to put the question in chat as well?
No, that's okay. I just wanted to make sure I feel like I heard folks maybe focusing on another part of the question, so I wasn't sure if we were still also answering the first part. Okay. Um, I feel like the way I incorporate harm reduction into my work is just it's kind of the whole scope of what I do. I try to take away maybe the barriers that folks can experience when reaching out for support at maybe a nonprofit, or maybe with speaking with their therapist or social worker. There's certain, and that would be the institutional um level, that there's certain things because of licensure or what have you that folks aren't able to offer as support, or maybe they don't know that they can offer these alternatives or just varying methods to people because they're not allowed. And me, I'm not certified in anything. I am just a person with lived experience who has something to offer to my community, and and then also just things I've learned throughout being present for my community. um I just try to, yeah, listen to folks and meet them where they're at and get them what they need, whatever it is, and try and maybe try to help them brainstorm what they need. And um yeah, and that's different from yeah, I said that. Okay. I think, yeah, and and sometimes people will come to my table and maybe because like at a free clinic or a nonprofit that might be tabling, they'll have to like sign in or like write their name or their demographics and things like that. And I don't necessarily do that at my table. Everything is free. And just yeah, just like what I mentioned earlier, trying to imagine a world where like bureaucracy and like paperwork isn't necessary, I guess. Yeah, thank you.
I really appreciate that. Having, like Joe said, low to no barrier in the chat. Being able to not necessarily be so dependent on recording the amount of care and the amount of people receiving care is really, that is definitely a barrier in terms of institutions because we have to balance like, are people receiving care with at what point does it become like aggregating data on people? So thank you for that. So the next question is, do you think societal attitudes around socially normative versus unacceptable harm shape people's feelings of shame around disclosing their experiences, like across the spectrum of acceptable to unacceptable? Vera?
Yeah, absolutely. I think that like particularly when it comes to like psychosis work, and like the early psychosis field, I think the places where this comes up the most is around ideas around suicidality and self-harm. And I think that that's something that can end up being very scary for consumers in general. I know that for me, in my own personal journey, like seeking treatment for my own mental health concerns and like receiving supports, it was a very large barrier for me to talk about my own experiences with self-harm and with suicidality with clinicians openly, largely because I felt like there would be potentially a response that would violate my autonomy, that would get me sent to an inpatient facility, that could potentially in some way end with me getting harmed or experiencing significant trauma. And I think that like engaging in more of like a harm reduction process or an acceptance of that behavior as being something that like there are supports for and that don't necessarily require like a carceral response immediately would have been something that would have felt a whole lot more supportive for me earlier on. And also I think that like when we think about self-harm, particularly as a practice, I always like to talk about the fact that there are very socially acceptable forms of self-harm and socially unacceptable forms of self-harm. I love my piercings. I have a couple piercings, got a couple punches on here as well. And those for me have been a great way of engaging in like a harm reduction practice where like a lot of those urges are no longer there when I'm engaging in a process that allows me to take autonomy and like how my body looks. And also, I think that there is like a lot of moral weight put on like the act of engaging in a self-harm behavior compared to like when somebody decides to engage in a form of bodily harm for the aesthetic. Because if we look into like the basics of what the action is, tattooing, piercing, body modification are all things that I would consider as being technically a form of harming your body, but with the goal of creating an aesthetic look that is ultimately more affirming to an individual. Self-harm, I think, serves a different role, but I do think also comes from a sense of a person trying to like exist in their body or exist in any current moment and feel comfortable in that existence, even if it's sometimes through a method that like traditional clinical structures would marginalize and view as something as being inherently pathological. I also think about like indigenous societies that like had sort of practices around self-harm as a form of ritual and sacrifice that were definitely socially normative at the time before colonization and until we imposed like biomedical structures were something that were normalized.
Thank you so much. I see Jill and Locke. Jill first and then Locke.
Yeah, thank you for that. I think what I might do here is tell a very, very quick story. Working at a syringe program in Holyoke, Mass. I was working with somebody and his demeanor he came in and he was so low and his head was down and doing my little exchange paperwork, asking what supplies he needs in terms of syringes and cookers and cottons and all these other things that we give out. And I asked him how he's doing and he's like, has such negative self-talk and telling me that his wife is mad at him because he's on methadone and he started using again. But in this story, he's also telling me that he's faithfully going to this Bible study once a week and then also doing like a new class once a week and all these other things. And I was just like, dude, how that's amazing that you're able to prioritize going to these things that enrich you in some ways. So I'm just sharing this because it shows that even within a little family, that one of the partners is like, oh, you're on methadone, you should not be using. Like that is their idea of recovery or being sober or whatever. When this other person is like, well, I'm still using sometimes, but I'm also like now engaged socially with these other things that I was never engaged with before. So I do think that there's so much shame in society around substance use in general. Another quick example, I had a friend that stopped drinking and not part of any program whatsoever, just stopped drinking. And then when he drank once again, he was like, oh man, I got to start from zero. And I go, who said? Well, you're not even part of a program. But that just shows that and that's speaking from AA perspective, that he had this ingrained idea about what a reoccurrence might look like for him, or that he has to set the clock back to zero when there's no one asking for accountability. So I think that's a good example of like these things get ingrained in us as people, and then that can kind of make us not want to disclose to folks what's actually going on.
No, I really appreciate those stories, and I think they speak a lot to the value of reframing our thinking around shame when it comes to what we consider recovery. I don't really love that word, but it's a word that I'm going to use in this context. Walk.
Hello, this is Locke Ironwood, they, them pronouns. I just wanted to speak on an aspect of what we're talking about, socially appropriate versus socially inappropriate harm. I think one of the most telling aspects of I've seen that be sort of reflected through society is by sort of the bodies that we live in. I've been recently doing a lot of work with people with eating disorders. And like people with eating disorders do not have a particular body size, right? But there is a lot of assumptions about how bad that eating disorder is, how severe it is, how much help you're warranted to ask for if your body looks a certain way, right? There is this concept of a person who's suffering from a severe eating disorder is going to look a certain way. And the more research that I do, the more people that I meet, the bodies are so different, and like the behaviors tend to be just a little bit of everything for everybody, you know? And it can be really hard, especially in the medical community, when someone reports an eating disorder, they're in a body in your brain that says to yourself, this person is just fine, and they don't get help. And in that, I think like for a person reaching out to a medical professional saying, this is what I'm struggling with, and I am afraid for this, and this reasons, um, that can be interpreted as socially acceptable harm because they just took that concern to a medical professional, and that medical professional looked at their body and said, that's all I need to know about you. So like it can be really interesting when you think about it in that case, because if someone comes in with like a particularly small body, says they have an eating disorder, they're more likely to get care for someone who is actually may not have the same sort of look of need, right? So there's an aspect of that that I think is really poignant in the research I've been doing in that front of things. And I struggle with that as like part of a dynamic that I see for a lot of people suffering, you know. And I do a lot of research on like fat liberation. I would really suggest folks reading the I almost forget what it's called. Um, the racial origins of fat phobia. I almost forget the title. I'll write it down in a moment. But it's about the racial origins of fat phobia. It goes into a lot of history. I will quickly look that up and put it in the chat. But thank you so much for listening.
Thank you so much for sharing. I really appreciate it. We only have one last question, and then I want to really quickly make sure that people don't have questions in the chat before we close out. So just a heads up to be conscious of our time. The last question is, what do we lose when we focus on approaches with the goal of abstinence? And a little bit of a follow-up question is, would the people we serve benefit more from us considering their perspectives? So that's kind of folded into the first question. Jill?
To answer the first part would just be lives. We lose lives when we focus on the goal of abstinence only, like period, blank, end of statement. Um, and I think in any of the work we do, and I'm not even certain all the context of all of you folks on here, where you're coming from in the field, but in any of the work that we do, of course, we should be listening to the person's perspective that we're working with. I don't know how we would work with somebody not do that, honestly. And a lot of these things that we've talked about, these bigger concepts, like we don't have, like, depending on your role, I know that we don't have time to go through somebody's complete trauma and all these other things, but those things do matter. Where people come from, that does matter. We're all carrying so much collective grief for so many different reasons, and having that awareness, even just at that, is really important, because we just have to look at each other as humans. um, yeah, thank you.
Perfect. Thank you so much for that perspective. I really find a lot of value in everyone's thoughts on this. Riot?
Hi, it's Riot. I feel like when we focus on approaches with the goal of abstinence, I think about what Vera had mentioned earlier. Abstinence is not the goal for everyone. It's not everyone wants to follow that method. Some folks would like to keep living their lives the way they already are. They might just need a certain type of support, like I think, like all of my colleagues mentioned already, someone might come in and speak with you, and maybe they do use drugs, or maybe they do self-harm in a certain way. But also maybe they're still like living their lives to the fullest. Maybe what they need support with is not what you are assuming they need support with. Ma- Is it that, is this person in crisis for what you think they are in crisis for? Are they in crisis at all? Or are those the words that you're using? You're assuming, perhaps because this person is chronically suicidal, that that's what they need support with. Maybe that's not what they need support with. Maybe they need support finding a job. Like what this is, like, I feel like one of the messages that we've been talking about throughout this whole panel. What is the person communicating to you that they need? Or are you assuming because you're the specialist, or perhaps the person with the certificate, that you know what's best for them? Thank you.
No, I appreciate that a lot. And I apologize. I just found out that we can go up to 5 past because we had a late start. So, sorry for cutting that short. Vera, I saw your hand up.
Yeah, absolutely. I really resonate with what Jill and Riot said. I think that like we not only lose lives, we lose like the trust of the people that we're serving. And also like something that I think is particularly relevant to like the scientists on this call and the researchers on this call is we lose scientific efficacy. When we don't actually look at the mechanisms of the effects that we're seeing, particularly when we're using things like correlational studies or ANOVAs, which from my perspective are just souped up correlational coefficients, then we start losing things like the mechanisms that drive those changes. If we don't actually look at why the data is reflecting the numbers that we see, and we don't talk to the people who are taking parts in our study and ask them, why are we potentially seeing this effect for y'all? Then we're not actually capturing a mechanism of what's creating an increase in whatever outcome we're looking at. And so, like, when we're talking about particularly like harm reduction, when we focus on the goal of abstinence, as being sort of the solution that we're applying to somebody's life without actually getting a complete picture of the mechanisms affecting their experience, then we're effectively just throwing a band-aid on a broken leg, and we're not actually affecting like the things in this person's life that would actually be meaningful, that would actually make them happier, and that by clinical standards would probably lower a lot of their symptom presentations. Which again is not something that I'm saying is particularly something we should focus on entirely. I think focusing the people that we care for are happy and able to live the lives that they want is the bigger focus. But if we're thinking even by like the metrics used within our research systems, it's not good science for us to not collect qualitative data and to ask people about their experiences. We need that information because it's vital context.
Thank you for that. I really appreciate those thoughts. Sorry, just making sure that the interpreter was done. Walk, did you go or I want to make sure everybody won?
Forgive me, I was trying to answer the question in the chat, so I will also go here. When I think about what needs to happen, right? When we're talking about like whether, peer I'm sorry, hold on a second. I'm getting my questions confused. I'm still looking at the one in the chat. 1 second.
What do we
Lionel, could
lose
you
when we
repeat the
focus
question
on
for me?
approaches?
Thank you.
Okay.
Got a little confused there. I apologize. So when thinking about approaches, I definitely go further into what's already working and like sort of the things that like we know to be true. Some of those things are kind of can often feel elusive to like clinical staff or like psychiatric staff or like supportive staff. They can feel elusive a lot of times because of the way information is often structured. So I think for me, it's about seeking out information that would not necessarily be readily available to you. Like there's lots of texts, there's lots of harm reductionists on this panel that would be willing to like, I'm sure, like to go into further discussion about like how we can incorporate more change and harm reduction into everyday clinical language and practice. So I think when I think about that, that's something that there's always the separation between clinical staff and like the people who have lived experience. And sometimes I like to say it out loud because it's one of those things that makes it hard to get work done sometimes. So I would love to see more collaboration and just like lots of more listening ears because we do a lot together. Together with we're able to accomplish so much more. So like I would love to see that happen. Thank you so much. And I will go back to answering that question in the text. Thank you.
No, absolutely. And I would actually really love to read it out loud and give people the opportunity to answer it just before we close out. Just because I think it's a really rich question. If people will be willing to do that. A question for the panelists is, how can clinicians support service users / consumers in exploring harm reduction spaces who are hesitant to engage in peer support communities and harm reduction spaces because of stigma / self-stigma or wanting to be different or better than folks who use those resources? So like that separation of self from resources that could be helpful to them in terms of connecting with other people. Um, I don't think that there's no way that you can lead a horse to water and get it to drink, honestly. So that's my personal perspective. I think that's a little bit goal oriented for me in terms of trying to get someone to access services, even if those services are peer-based. So I just want to open the floor to that. I apologize for inserting my own thought there, but I know it's a complicated topic. So, Jill?
I would, with all due respect, I would say there might be some humility conversations that can happen around this with the participant or client. And I've seen this even within syringe exchanges, that folks who smoke crack and come in to get pipes are so different from the people who come in and get needles for injection. So that even happens within the drug using culture and community. Um, and oh, I just lost my train of thought too. So I think in terms of clinicians, the other thing is, and this might be a radical idea, but like, do you have time and space in the way that you work to bring somebody to a harm reduction drop-in center, to bring somebody into these spaces? Or is there another peer that you work with that could bring somebody into these spaces? And I think with harm reduction, specifically public healthy wise, getting people to understand the risks. People can test their drugs at these places now. There can be community within that as well. So I think telling people, what these programs actually are, but also that means whoever the clinician is educating yourself on the local resources that you have, so that you're not just like, we are doing these warm handoffs. And I also think, telling people that like the harm reduction stuff started for you and by people that use drugs, that might also spark some curiosity.
No, absolutely. And I apologize if I seem prescriptive. I meant more in the sense of like, I think for me, I can very easily tell when someone is doing a goal rather than being curious about my experience and how I engage with the service. So I think I felt a little bit in that orientation when I answered that question. Does anyone else want to speak to that question? Vera?
Yeah, absolutely. I think that particularly when we think about the training that most clinicians receive, I personally don't think that the majority of clinicians that I've met in any of these clinical spaces are exactly community professionals. And I don't believe that like it's part of clinical training to receive that sort of community engagement. So I always cringe when I hear that the majority of somebody's clinical outreach and community engagement operations are being done primarily by somebody who's a clinical staff person. Peer specialists are community professionals. Caseworkers are community professionals. Even family peers are community professionals. Their skill set, their training, their experience is geared towards talking to people in community and connecting them with community. I think clinicians can play a role with that, but also I think we need clinicians to stop overestimating their experience and expertise on skills that they did not hone through their training. CPSs did do that. Caseworkers did do that. Social workers did do that. And if we're thinking also like expanding that to like admin professionals, like we shouldn't be having clinicians do admin-based roles either because again, they don't have any admin-based training. So while I do think that it is important that we build our capacity for clinicians to connect people to these resources, I think it is a mistake to rely on them.
Mm, that makes sense. It is 1:06. We went 5 over because of the late start. So I just wanted to start closing out and thank everybody for their time and effort in answering these questions as well as sharing your thoughts. If you want, you can put your email in our chat. I will be putting my email in our chat if anybody wants to contact me after this for further thoughts. But other than that, just reading chat. Other than that, that's all I've got. Thank you for coming and thank you for presenting.
Thank you for having me. Olivia, I just dropped somebody's name in there. You asked for folks who are familiar with harm reduction with families and teenagers. Dee Dee Strout has an amazing website with all these different resources for parents and families and all this stuff. So I would check that out.
Awesome.
And
Take
she's a
care.
clinician too.
Oh, perfect. Thank you so much.
Thank you, everyone.
This is Riot. Thank you so much for having me.
So that I think we all need to take a deep breath. I really appreciate just the very frank and engaged discussion of the panelists and everybody participating in the chat. I think we all have a lot to kind of take away with us.